I'm Ellen Binns, coming today from Wheaton, Illinois, in the USA. Welcome to Impact, a podcast about how we can each bring about real change in the world and getting practical in making that happen.
And hello, I'm Clive Johnson, coming today from what may sound as a very noisy Blackpool in the UK. Won't go into too much detail, but where I was meant to be recording, the internet has gone down. And so I have transferred to another hotel reception with all its noises of coffee machines and people checking in at reception and background music. So not the most ideal circumstance.
That's all right.
But we thought we'd go ahead and hopefully you can enjoy the life of Blackpool in the background. So a special welcome if you're listening for the first time, and a big thank you to our new subscribers. Each week we look at one aspect of how we can connect our hearts to offer healing for others with our collective intention, prayers, and meditation, and go behind the headlines of a critical happening in our world that needs our attention right now.
In today's episode, we take one of these regular deep dives to more fully understand and tune in with something many of us may know only a little about, and I guarantee you'll learn a little bit about this, no matter how much you think you know, and see where we might hone in with our prayers and intentions. And as we record, it's July 23rd, 2026.
So this week, we are turning our attention to a service that's very close to our own hearts, and perhaps those of many of our listeners as well. The typically very dedicated and important service offered by hospices in many countries worldwide. We look at how hospices began, how they're funded, and how they differ from location to location, sharing what our research revealed are some interesting facts along the way, before turning attention to see where we might focus our intentions, prayers, and praise in honor of the hospice movement and those who give their caring and dedicated service to them.
And we might add that we're doing this topic because we each have been dealing with hospice.
You have indeed.
Lately.
Yes. Yeah.
Right.
Yeah, absolutely. We know.
Clive, you just lost a friend
Yes.
who was in hospice, and we extend our sympathies to you, of course.
Bless you. Thank you.
And as listeners might know, my dad was on hospice last year and passed on October 29th, and my mom is now on hospice.
Mm.
So we thought, we've learned a lot, and some of what we've learned, you learn just by going through it.
Yes.
And working with hospice people. But we can share what we know and also give a little history.
Indeed. And this is really interesting, isn't it? Yeah.
So let's start by asking what hospices are and where they began. Hospice care grew out of a Christian charitable concern for pilgrims and the dying into what has become a modern, global, multi-skilled offering for supporting patients at end of life and others who need long-term palliative care, closely linked with but distinct from treatment they might receive at a hospital. Hospices may now offer inpatient units, home-based teams, and children's hospices, funded through a mix of public health systems and charitable giving that varies markedly between different countries. The word hospice itself comes from the Latin hospitum, meaning hospitality, or a place of rest for the ill and weary, originally used for shelters for pilgrims and travelers during the time of the Crusades. Medieval hospices, run by religious orders such as the Knights of Hospitaller, and later Catholic and Anglican communities, offered refuge and care for the incurably ill and dying, especially in France, Ireland, England, and Australia. Modern hospices, and the specific approach they provide for palliative care, began in London in the 1950s and 1960s through the work of Dame Cicely Saunders. She founded St. Christopher's Hospice in 1967 with a service that integrated rigorous pain control, social and spiritual support, viewing total pain as a combination of physical, emotional, social, and spiritual suffering, all of which hospice care recognizes and seeks to address. This holistic concept of caring for people's whole beings continues to be important in care provided by hospices. This follows the teachings attributed to the Greek physician and philosopher Hippocrates that it is far more important to know what person the disease has than what disease the person has. We might also quote the similar teaching of the 19th century American physician, Dr. Edward Trudeau, who said that the purpose of medicine is to cure sometimes, to relieve often, and to comfort always. From St. Christopher's, the model spread rapidly. Early services appeared in North America in the 1960s and 70s. For example, the first palliative unit in Montreal being established in 1975, as well as in Europe, Africa, and Asia. The first modern hospice in the United States was Connecticut Hospice, set up in 1974 in Branford, Connecticut by Florence Wald, a former dean of the Yale School of Nursing, who had been inspired by what she saw at St. Christopher's during a visit to London.
Yeah, interesting, isn't it? And I love those quotes.
Yeah.
Really the attention to caring is
Yeah.
absolutely what is primary.
Yes.
I think that word hospitum is also a root for obviously hospital, but
Right.
also I think it comes from the same root as words like home, hove,
Yeah.
haven. This whole idea of providing like a safe, welcoming space.
Yes. Yes.
Beautiful idea, really. It surprised us how relatively recently the modern hospice movement began, as we're saying. It's only really back in the
Yes.
1970s they appeared in North America. However, we were reminded that before the availability of antibiotics, death often occurred suddenly and was usually related to infectious diseases rather than chronic illness, as is much more the case today. So back in 1910, we're looking a little bit over 100 years ago now, the average life expectancy in the United States was just 50 years. Pneumonia, influenza, tuberculosis, and diarrhea were all common causes of death. The excessive number of deaths caused by COVID-19 is estimated globally at around 27 million, although likely much higher. And especially those before vaccines were available and widely distributed, might give us a sense of how terrifying it must have been to live in the age before modern medicine. Possibly also the HIV/AIDS crisis might also come to mind as a time of fear for many. However, for most of us in the Western world, the prospect of dying from an infection is far less a concern than for our grandparents and earlier generations, albeit great strides have been taken to win the war on cancer. Many of us in the Western world have seen how much life expectancy has continued to change during our lifetimes, as medical advancements now mean that many acute illnesses can often be treated successfully. We live in an age in which antibiotics and vaccines are available, and in which scans and blood tests can often detect some conditions at an early stage. Before this became possible, care was mainly directed at treating symptoms. So let's be clear about what the term palliative care means, which might not be obvious for some of us non-medical folk and probably wasn't in the vocabulary really of most people before the 1970s.
I think a lot of people still don't know or
No,
familiar
no,
with the word.
and even within some in the medical profession as well.
Mhm.
Yeah.
Mhm.
So the term is now often used alongside hospice to describe the active, holistic care. That's what, as we were describing earlier, this looking at their all-round needs,
Mhm.
particularly people whose disease is not responsive to curative treatment. That includes support for families as well. Palliative care is this holistic care aimed at relieving suffering and improving the quality of life for people with serious, often incurable illnesses, rather than trying to cure a disease for which medical consultants may consider a patient beyond treatment that a hospital might provide. So, as we say, hospice is the place of hospitality or service providing this care. I think it was certainly the case with my friend that when a referral to the hospice was made, it was the hospital was kind of beyond the point where it felt it could
Yeah.
offer any
Mhm.
useful treatment of that stage,
Mhm.
essentially
Right.
a life-threatening condition.
Mhm.
Global mapping by the Worldwide Hospice Palliative Care Alliance and also World Health Organization shows that hospice or palliative services are present in most countries, but with a very uneven pattern and access to them. The Global Atlas of Palliative Care estimates that millions of people require palliative care annually. with around three-quarters living in low and middle-income countries where services remain minimal or are not there altogether. Regional maps for Africa and other areas highlight that some countries, such as Uganda, South Africa, and Kenya, have relatively dense networks of hospice and palliative services, while others still lack any identified specialist hospice provision. There is a day, which I don't think I've come across before, World Hospice and Palliative Care Day, as held in October each year, is first marked back in the mid-2000s, created to raise awareness of the role and importance of hospices globally and to advocate for more equitable access to end-of-life care.
And what a lot of people don't know is that hospices typically perform a number of vital roles. Probably they're best known for providing inpatient care at the end of life, but their roles are broader than this and increasingly diverse. Certainly, providing residential or inpatient care for people in their last months, weeks, or days of life remains important, with hospices aiming to help respond to symptoms while providing psychosocial and spiritual support and giving space for families to be present. However, many hospices also offer home based palliative care, where interdisciplinary teams visit patients to manage systems, provide nursing care, support caregivers, and coordinate with community services. This may include offering 24-hour support for a patient who is dying. And that's what I've experienced is the in-home support and care.
Mm, mm,
Unfortunately, we haven't gotten the 24-hour support in the
mm,
US. That's not provided. And but we do have a hospice facility near us that I know some people
mm,
have
mm.
used at the end
Yeah,
of
my
life.
friend had the 24 hours specialist nurses coming in as well, only for a couple of days.
Yeah.
Literally, he didn't sadly last
Okay.
very long, but that was there.
Support for families before and after death is also important, and I can say amen to that, which may involve a mix of counseling, bereavement support, social work, and group programs. Now, I don't know about your hospice, but we have chaplains and we have music therapy. I think there's even massage therapy that will come in and social workers who talk to the family and to the person. And as we know, sometimes people aren't ready for death. And
Yeah,
I think they're wonderful in talking to people about what the process is going to look like, helping them get ready and just, like working with everybody because
I
there might
actually
be.
have contact with my own local hospice. There's actually two hospices. One's for the adults and the other's for teenagers and children. And yes, we have chaplaincy. I basically am a contact for interfaith, not so much as a chaplain. I tend to offer that support to the staff and volunteers there. And it is quite an eye opener to see the wonderful range of facilities and options there. And and yes, for those who perhaps have an untreatable condition, but is life threatening, and therefore there may be some ongoing care over a long time, the sort of day care, come in, enjoy some of the facilities, workshops, or whatever they are, different meditation practices and so on is
Right.
very, very valuable, very helpful. Yeah.
When my late husband died, we also had hospice for him. He died of pancreatic cancer. I took advantage of the
Mm,
post-death
mm,
bereavement
mm.
groups.
Yes, 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 yes. Yeah,
Yeah.
absolutely. Yeah.
And many hospices also now provide day services, like you said, and outpatient clinics where patients attend for pain and symptom review. I don't think we have that in the US. Physiotherapy, complementary therapies, and social activity while still living at home. They may engage in providing education and training for health professionals and volunteers in palliative care principles, communication, and ethical decision making, as well as being active in advocacy and research to improve national policy, raise awareness of palliative needs. How about raise awareness of the palliative word and develop evidence based care models?
Mm, mm. Yeah.
So they go beyond the scope of just their patient care too.
Yeah, and I guess it's evolving as well, isn't it?
Yeah,
Because the reasons people are dying and
yeah,
the perhaps sometimes the length of time of
yes,
process is
yeah,
extending. So it's not a case of staying still. It's really responding to individual needs, particularly.
Yeah. Yes.
Yeah. There are also some lesser known roles that some hospices undertake, including in children's and long term care. Children's hospices and pediatric palliative services have grown significantly in recent years, especially in the UK. Certainly in the hospices I'm linked with, there is an amazing children's teenage persons facility, not very far from where I am, actually. Unlike many adult hospices, and this was a real eye opener for me, children's hospices often accompany families over several years, is not just necessarily some uh, fairly short-term illness.
Yeah.
From diagnosis of life-limiting conditions through to complex treatment, respite support, and of course bereavement care, patients may be diagnosed with a terminal illness as young children, yet even pass through the growing pains of coming into their teenage years, while both they and their families know that their expected lifetime is likely to be cut short. Perinatal palliative care is another emerging area where children's hospices work with fetal medicine and neonatal services, helping families who face life-limiting diagnoses in pregnancy or shortly after birth, including advanced care planning and memory making. Children's hospices may also offer long-term residential care for young people with severe neuro disabilities or degenerative conditions, not only at the very end of life, but across, as we were saying, across quite prolonged periods. And in some regions, hospice and palliative teams are supporting patients with chronic non-cancer illnesses such as heart failure, dementia, and HIV/AIDS, again, sometimes for extended periods, aiming to enhance the quality of patients' lives alongside offering disease-focused treatment.
And I guess my mom would fall in that category. My mom has advanced stage chronic heart failure and pulmonary fibrosis, not cancer. And going to the doctor and to the hospital is extremely difficult at this
Mm,
stage.
mm,
So she
mm.
qualifies for hospice because it simplifies life and it gives us a support system in the home that, I mean, these diagnoses are chronic and will eventually lead to her passing, but we don't know when. And so it doesn't have to be, I think people picture hospice as being within a week
Mm.
or 2 or 3 days, hospice comes in and that's the end, and that's not always the case. My dad was on hospice for 6 months.
Yeah. It can be quite some time, can't it? Yeah.
It's really a wonderful support system, and I think we wanted to do this podcast to help people understand that,
Mm, mm.
to not, flinch at the word hospice.
Yes, absolutely.
It can be positive. Historically, hospice care was strongly rooted in faith communities, particularly Christian religious orders offering hospitality and care to the dying poor. Early modern hospices in Dublin and London, such as Our Lady's Hospice and St. Joseph's Hospice, were established by religious sisters, and many subsequent hospices worldwide came out of church or mission initiatives. Today, hospices continue to include some that are explicitly aligned with faith traditions. These are often Christian, but also include Muslim, Buddhist, and Hindu associations, where spiritual care is shaped by that tradition, but offered to patients of any or no faith. Secular charitable hospices also exist. Non faith aligned hospices are common, yet they too usually provide spiritual care chaplaincy and support tailored to diverse beliefs and practices, and may themselves have moved from a previous faith based association in name and stated mission if the same principles remain integral to their ethos. Spiritual care within hospice typically encompasses chaplains or spiritual care practitioners, supported prayer or ritual, exploration of meaning and fear, and sensitive attention to cultural practices around dying and bereavement. Interfaith and gentle exploration of the sacred for people of no faith background may also be supported. And this is a field that you have interest in, and you're beginning to help support your local hospice, right, Clive?
Yeah, I am. And I feel a little bit of a fraud almost in doing it because, of course, I'm not there as the staff and volunteers are all the time, seeing all the different conditions. I'm very rarely there, in fact. But trying to explore collectively together and learn together how we can talk to people who do not have a faith tradition, particularly those who, let's say, don't want to be evangelized. There's real sensitivity around exploring these topics in a gentle, opening way. And for those who are offering the care, of course, there are also very strict protocols, nursing protocols, and so on around what they can and can't say as well, for very good reasons. So as questions come up for them, which can be as simple as, will you pray for me? Knowing how to answer that is not necessarily as straightforward as we might imagine.
Right.
I am looking, the particular hospices I work with, they're introducing a wonderful facility where through their TV screens in the patients' rooms, and I imagine this would be available through their website for those who are tied in at home, they can listen in to meditations and talks and tailor it according to where they are in their faith journey or lack of one. So one of my next projects, I've already given them the number of meditations that can go on there, but one of my next projects is to try and really look at producing some of these very introductory talks around matters spiritual without putting a faith emphasis on it. And I suspect that's going to be quite a learning experience, because what I will do, almost certainly there'll be folks there who will say, well, you've got to be, you're got to be careful with someone who's at this particular point or is not able to understand that, or anything that is presenting something as fact, shall we say, or the way is definitely going to be disrespecting someone's free agency and so on. And also not, people's capacity to actually think and to work through when they're very tired, they're very confused, perhaps don't even know where they are.
Scared.
It's hard. It's hard. So this is going to be interesting work, I think.
Yes, I think it's fascinating.
Yeah.
My friend John O'Donoghue once told me that he thought it was a privilege to be with someone when they passed, when he was a priest. It was one of his favorite parts of being a priest, was being with people as they passed. And I agree. I've had the privilege of being with several people when they passed, and I find it very humbling and sacred.
Yeah. There can be a great sense of serenity, can't there? And that kind of real supernatural, some would call it angelic holding and divine holding, whatever language you use. Yeah, I'm totally there as well on that. It's a ministry I'm personally drawn to.
Yes. I'll steal another word from John. You probably know, he always uses the word threshold. And I love being at that threshold with someone where they're entering it's just such a privilege.
Yeah. So in some countries, hospices often function as part of wider health systems rather than as separate, entirely separate charities. Coordination with hospital services helps avoid fragmented care at the end of life and frees hospital services to focus on caring for patients who may be responsive to cure-focused treatments. That's quite important in the hospital system, where there are relatively few beds, of course, as well.
Yes.
So it's, along with social care, or ensuring that when people are discharged from hospital, they're going to be able to be in a safe environment if they're going home and so on, is providing that vital service as well. So in the UK, for example, hospices collaborate closely with National Health services through shared care pathways with hospital clinicians referring patients to hospice or community palliative teams, and sometimes continuing joint follow-up. Multidisciplinary palliative teams who bridge hospital and hospice, including consultants, nurses, social workers, therapists, and chaplains, and in statutory commissioning. Integrated care boards in England having a legal duty to commission palliative and end-of-life services, which often includes contracts with local hospices for inpatient, community, and children's care. And in the USA, hospices are integrated with the Medicare hospice benefit, with accredited hospice organizations providing services at home, in nursing facilities, or dedicated inpatient units. while hospitals continue to handle acute admissions unrelated to terminal conditions. Care coordination typically involves sharing medical records and referral protocols and agreements about when a patient might transition back from hospice to curative care or hospital admission. So it doesn't necessarily mean if you find yourself in hospice care that you cannot be referred back for other treatment.
Right. Right.
Obviously, things change.
Exactly.
Yeah. In many low and middle income countries, community-based models are often relied upon, where hospice or palliative teams work alongside primary healthcare and district hospitals, using toolkits and training programs to embed palliative principles into their work, and often working with limited resources. We should hunt out. You were talking about John O'Donoghue there, your friend, and he's always, when you mention his name, his beautiful book of blessings, or several books of blessings, Benedictus comes to mind. I'm sure he will have blessings in there, won't he, for the passing?
Yeah, I believe he does. Yeah.
I'm sure they'll be there. Those would be ones to hunt out.
Yes, they would be. Yeah, you might want to use that for your friend's funeral that you are going to
Yes,
officiate.
that is a thought. That is a thought. Yeah.
So the approach to funding hospices varies by country. And this was what we were interested in when we first brought this subject up. How does hospice vary around the world?
Yeah.
In the USA, hospice care is mainly funded through the federal Medicare hospice benefit, which covers most hospice services for eligible patients. Medicaid, the joint federal state program for low income individuals, also offers hospice benefits, though coverage details vary by state. Private health insurance plans, employer schemes, and veteran administration benefits add to the funding of hospice care for those who don't rely solely on Medicare. Many hospice organizations, particularly nonprofits, supplement these sources through charitable donations and grants, enabling reduced cost care for uninsured or underinsured patients. Across the pond, most UK hospices are independent charitable organizations that receive a minority of their income from the state and need to raise the remainder from donations, charity, shops, and legacies. Parliamentary and sector analysis indicate that, on average, around a third of hospice running costs in the UK come from the NHS and government sources, with the rest, over £1 billion per year, are generated by hospices themselves. Adult hospices usually have contracts with NHS commissioners for specified services, but statutory contributions vary significantly between regions, producing what advocates describe as a postcode lottery for end-of-life care. That's not a good thing to have, right, Clive?
No, it isn't. It isn't. I think it's true of a lot of healthcare in the UK because it is kind of the responsibility of individual trusts. So the particular area you're in, there will be a trust that has a budget and a lot of discretion in how that is used. And there will be a variety of challenges they're facing. But, perhaps a lot of the focus is put on hospitals, but also, I believe, individual general practitioners are funded by the same trust. And so the actual care patterns of people varies depending on, for example, the demographics. If you have a lot of older people in your area, for example, who may need a lot of specialist long-term care, then there's going to be more pressure on the finances. And therefore, in theory, I would imagine that's going to reduce the potential for funding hospice care. So actually, it strikes me strangely, the US model is possibly slightly better to the UK.
Yes.
We often talk about NHS as being a service which I am really grateful for. But in this instance, I think it can work the other way.
Yeah. And to add to that, children's hospices receive proportionally less local statutory funding, although the central government has created specific grants for these and promises additional capital and revenue funding to shore up the sector. In many other countries, hospice and palliative care funding is fragmented and often inadequate, combining limited public health funding, mission or faith-based support, and international or local charitable fundraising. Low government priority for palliative care and restricted access to opioid analgesia, that is, pain relief medicines, frequently constrains the development and sustainability of hospice services in these countries. I believe, and I might be wrong, I'll have to ask my husband who's in healthcare about this
Mm,
question, but I think hospice is just way more cost effective than keeping someone in the hospital. And that's why Medicare is willing to do it.
interesting, isn't it? Yes.
Mhm.
And
Right.
yes, I mean, given the attention you get when you're in hospital, which is constant, isn't it? It's
Yeah.
uh, everything's being monitored constantly because you're still in the treatment mode
Yes.
essentially and monitoring of everything. And whereas, I guess the burden for that, for one thing, is not as high in a
Right.
hospice.
Right.
Um, but coming back to those wonderful quotes earlier about the kind of care you're getting, it is likely much more appropriate.
Yes.
Certainly, I know my friend, he'd been in hospital for around about a month and was to come out, desperate to come out. And happily, his last wish to go home with care, the hospice care provided, was granted ultimately. So much for the background and what they do. Now we turn attention to some of the challenges many hospices are now facing. Among the most pressing is financial instability. Rising costs, inflation, and workplace pressures have produced significant funding gaps for many organizations. UK analysis reports tens of millions of pounds in sector deficits, forcing some hospices to reduce services or face possible closure. Strain on the workforce is another major concern. Recruitment and retention of specialist palliative nurses, physicians, and allied professionals can be difficult, especially in rural areas and low resource countries, impacting service capacity. Many hospice staff work long hours. Yes, absolutely. Incredible. Sometimes voluntarily or for limited financial return, and must deal, as we were saying earlier, deal very sensitively and often urgently to the critical needs of patients and their loved ones. Globally, there is limited access to hospices, as we mentioned earlier. Many people who would benefit from hospice or palliative care can't access it, particularly in low and middle income settings and among marginalized groups. Another surprising challenge some hospices face is a misunderstanding of their role. We hinted at this earlier, didn't we? Even
Mhm.
among some healthcare professionals. Specifically, palliative care is sometimes associated only with imminent death, which can delay referrals and prevent patients from receiving supportive care earlier in their illness. Again, as we're saying, even though this can often be the place that patients need to be. Then there can be policy and integration gaps. While some health systems now mandate palliative services, implementation is patchy, and hospice funding models are often criticized as not being fit for purpose. For faith-based hospices, additional tensions may emerge around maintaining their explicit spiritual identity while serving broader communities inclusively, sustaining donor support as religious affiliation changes, and engaging in ethical debates about end-of-life choices. I know that's the case with the hospices I'm connected with. They used to be Christian based and focused. They were inclusive. Anyone would go there, but that was their part of their mission and their ethos and so on. So moving to a non-denominational framework is interesting, I think, that they've gone through that
That here,
process.
I've not experienced it that we have faith-based hospice care. It has always been inclusive of, they ask you
Hmm.
about your faith and they want to meet you where you are and provide for your beliefs, but there's nothing imposed or implied.
I don't know much about how that particular hospice operated when it was under Christian, but I'm sure they would have had access to other chaplains as well and been inclusive. But in terms of, it's interesting. I've not really asked the question how it's changed, but their kind of founding mission, their purpose, and so on would have been framed
Mhm.
differently for sure. So, where might we hone in with our intentions and prayers? So, this is the point. As always, you might wish to bookmark to come back to. We'll put a bookmark in the show notes if you want to find this place quickly. And as you do so, allowing yourself time and space to pause between each of the suggested intentions. So just taking a moment to allow yourself to become fully present wherever you are, letting go of external distractions as best you can, maybe closing your eyes for a moment, noticing your physical connection with the ground or whatever is supporting you, and becoming deeply connected with your own ground of being as we open up to these intentions that we offer. We will that all with influence in governments, medical health insurance providers, health trusts, and health commissioners in states where hospices are active will be moved to recognize the vital role hospices play in the integrated health and end-of-life care of patients, and will be minded to ensure that their funding needs aren't marginalized or allowed to rely on private or voluntary contributions. We ask that hospice staff will not have to compromise care or close services because of deficits and rising costs that aren't being addressed by those who make the funding decisions.
We pray that the many who work and volunteer in hospices will receive regular acknowledgement for their service, be protected from abuse, and be energized and sustained in light in their difficult, dedicated, and often long hours of work. We ask that they receive the support they need within their work environments to guard against the burnout and excessive stress that may result from their work.
We ask that all who provide palliative care for patients and support for their loved ones will have wisdom to know how best to care, serve, and communicate with them in every circumstance, according to their level of faith and mental or emotional state. We ask that this includes understanding and upholding their safeguarding needs and adhering to any guidance and codes of practice relevant for nursing professionals.
We pray that hospice workers and volunteers who have faith will be guided in how they direct their care for patients, doing so silently, prayerfully, and with openness to divine guidance, while respecting the no place to evangelize ethos that protects a total care focus for patients. We ask that hospices that are continuing to transition from faith-based to non-denominational and fully inclusive safe havens for care will be guided in their path.
We ask that pioneers in countries or areas where access to hospices is limited or unavailable will be inspired and guided in their campaigns to establish new or expanded hospices where they are most needed.
And we pray that there will be widespread education for all healthcare providers to ensure they understand the nature of palliative care and are aware when referring a patient for hospice care when it may be appropriate.
We ask that the management teams in individual hospices will have wisdom to know how to deploy the scarce resources available to them to ensure the highest good.
And this week, as we reflect on the invaluable service and special challenges faced by many hospices worldwide, we suggest holding as our main intention. We give thanks for the vision and commitment of the founders, continuing flag bearers, and all the workers and supporters of the worldwide hospice movement. We ask that they continue to be inspired, guided, and sustained in providing their vital service. Please join us in holding this.
Wow, my goodness, this has been quite a learning, hasn't it, really?
Yes.
Quite a learning, quite hopefully inspiring as well for
Yes.
listeners as well as for us. Really wonderful work that is being done and continues to be done.
And I think our hope was that it would be helpful to our listeners if they're ever in this situation. They can think back on
Yes, indeed.
some of
Yes,
the things
indeed.
we've mentioned, experienced, and of course, they can always reach out to us. We
Exactly.
are totally
Absolutely.
available if they have more questions, want to know
Absolutely.
more.
Absolutely. And I was going to apologize again for background noise, but it was just occurring to me, I'm in a place of hospitality. I mean, it's a different kind of
Yes,
hospitality.
that's right.
It was the quietest place I could find, but it's still noisy. So let's embrace. Hopefully, it's not been too distracting.
Right,
And next week,
right.
hopefully, we will be in a different. Well, I will be in a different place next week. That's almost certain.
Okay, good to
Not
know.
planning to be in Blackpool next week. Planning to be in
Okay,
Brighton, another
okay.
seaside place. So that about wraps it up for this episode. Remember, you can connect with us in the Facebook group and for live intention holding in my daily Insight Timer offerings and with Ellen in the Labyrinth Activist Network's Zoom calls. Details of how to hook up with these are in our show notes. Look out too for our next special topic episode, which we'll be releasing in the next few days. Thank you for listening and for sharing with us in Holding Intentions. We look forward to connecting again next time. In the meantime, thank you, go well, stay safe.
And remember, we're more powerful together.
Impact is presented by Ellen Bintz and Clive Johnson and produced by Impact Productions. Our theme music is by Chris Collins and our logo artwork is by Auto Classic. Subscribe wherever you get your podcasts and please leave us a review on Apple Podcasts, Spotify, Audible or your favorite podcast provider. We're a non-commercial podcast dedicated to people of any faith tradition or none who yearn for healing in our troubled world. Please pass on the word so others may join us in making an impact. Thank you for listening.